But I might get the second speaker up, Dr. Shozo Ishihara, and this is a very important topic on tips and techniques of retrograde CTO.
Okay, thank you, Jefferson. So today I'll talk about the retrograde CTI. This is not a new topics, but so some doctors are still trying to retrograde, or we have to educate for young PC operators. So that I talk about a little bit fundamental issues. Nothing to disclose. So as previous talk mentioned, so there are so many algorithms of CTO wire crossing, and also this is a very famous one. And so we can see, sorry. To consider about the retrograde approach, we have to at first pre-operative strategy construction is very important. So then we should discuss, and also we should carefully reading of the CAG so to check the proximal cap, distal vessel quality, and also there are any retrograde options. So it means interventional collateral. So it is very important. And this is a APCTO algorithm, very famous one. And so this one also showed the poor quality distal vessel, and also are there any bifurcation at the distal cap? It's also very important factor to consider about retrograde approach. Yes, and so antegrade or retrograde, it is a question. For in some cases we can do both, or in some cases we can do only antegrade, or we must do retrograde. So in some situations, but to do retrograde PCI, we should consider several factors. As first one, hospital and operator factor, and another one is a patient background, and the third one is a lesion character. So for hospital and operator factors, what means? So retrograde approach experience is also very important. If the operator is the first time for the retrograde approach, it is somehow risky. So that we should learn from expert or something. And also not only operators, but also the assistant doctor or assistant staffs also understand what is a retrograde approach, what is the risk or complication of retrograde. It's very important. And also, sorry, and also we should prepare double pressure line. It's also very important. In some Asian countries, still it is difficult to prepare double line. It's very important. And also heparin control. If we use the retrograde, it means the donor artery. Thrombus formation is totally dangerous. So that we should check ACT. This is a mandatory. And prepare for complications. Also important. Coil embolization for perforation or pericardial centesis or support device. In some situation, we need IABP or something. And approach site and also access route also important. If we do the retrograde approach, we have to insert double guiding catheter so that both radial or radial femoral and are there any stenosis or occlusion in the iliac artery, such kind of assessment also very important for retrograde approach. And also renal function is also the one important factors. If we have to reduce the usage of the contrast volume, at that time retrograde approach is a very good option to reduce the volume, contrast volume. And another one is good for the patient. So for retrograde approach, procedure time is okay, or if the patient is too much fatty at that time, X-ray dose is also the very important factor. And next one is the lesion character. Lesion character is, as you know, so JCTO score is one of the important factors. So entry, calcification, bending, length, and retry lesion or not. These are the very one of the assessment of the lesion characteristic and the difficulty. And another issue is also not only these factors, but also the CTO entry is unclear, or are there any severe calcification or something? These are included in the CTO scoring, so JCTO score something. But this is also important, as I mentioned, linear failure. So if the linear function is not so good, at that time we should consider retrograde. And also, are there any existing large bifurcation as a distance of CTO? In APCTO algorithm include this distal bifurcation. Also, but it's also very important. I show one case of the distal bifurcation case. This is our CSCTO. The lesion length is very short and no bending, and so no calcification. So it looks very easy. This tip injection showed still CTO, no microchannel. But I start from the XTR wire, but unfortunately, XTR wire couldn't pass, and it migrated subintimal. So that I used the Gaia first wire. So fortunately, this kind of short lesion easily cross the with the Gaia first to the PD branch. But after the balloon dilation with small balloon, a PL branch was occluded. This kind of bifurcation is very important to assess the both branch. Is important. So using double lumen catheter and also axiom black wire. Fortunately, in this case, fortunately, I can close the wire. But in some situation, second wire, we even using microcatheter sometimes migrate into the subintimal and hematoma formation, and sometimes we cannot get another branch. This is a problem. So that fortunately, this case was okay. But in some situation, we sometimes lose one branch. For that purpose, we sometimes have to choose the retrograde approach. And this is a interventional collateral. As you know, there are so many collaterals. Of course, as you know, first choice is septal, but we have to choose sometimes epicardial or somehow tortuous collateral channels. So how to choose interventional collateral channel? Is it the septal or epicardial? Size or tortuousness, and also we have to check the interventional channel, not only the initial angiography, but also the super selective tip injection, so microcatheter injection. Sometimes show it is okay or it is too much risky or something. And sometimes if it is not clear, but we can sometimes do septal stuffing with slippery guide wire, for example, XTR or something. And also, if the collateral channel is not clear, but if there is a very big main collateral branch, at that time we block the flow of the main collateral branch so that we can sometimes find another septal channel or another channel. So it is also another option. So there are so many, there are several scoring system of the collateral channel, J channel score or CC score like this. So, and also, the channel crossing wire is maybe, as you know, so the maybe mainly used to Sion or SO03 is mainly used. And if it is difficult at that time, we sometimes choose XTR, Sion black, or field IFC, such kind of slippery wire. And after crossing the wire, but we have to cross microcatheter. And at that times, we sometimes use a balloon anchoring for the guiding catheter support. And if the one first microcatheter couldn't cross the small channel, at that time, we have to exchange microcatheter from, for example, Corsair to fine cross or fine cross to Caravera or something. And septal channel dilation with small balloon is sometimes one option, but epicardial channel is too much risky with balloon dilation. Only septal channel is okay. And after microcatheter passage, if we strongly advance the microcatheter to the channel, at that time we have to be careful of the dissection or perforation, so that we have to prepare hemostasis. And if we cannot cross retrograde microcatheter, even using backup, balloon anchoring or changing microcatheter, anything, but it's difficult. At that time, antegrade wire cross, it means that kissing wire is of course one option. And also sometimes we do the retrograde guide wire direct cross so that we can do the tipping technique and the antegrade microcatheter can advance. So after the wire, to get the guide wire crossing, of course, we have to insert the wire into CTO from retrogradely and also antigradely. After that, we can do the reverse cut technique. And as I mentioned, so kissing wire technique is also one option. Yeah. And if the advancing the wire into CTO is sometimes difficult. At that time, knuckle wire technique is also one option. And after crossing the wire, and at that time, we have to advance the retrograde wire into antigrade guiding. At that time, if we can use short length guiding catheter is better. And also, we can use another option, using guiding extension catheter to pick up the retrograde guide wire. And if it is also difficult, at that time, we can change the guiding catheter, antigrade guiding catheter, for example, from plus 1 to JR or something, and use snare is also after one option. So I will show one case of the circumflex CTO with bifurcation. So sorry, it's okay. Sorry. It's not moving. So that I will show the content. So we can see the circumflex CTO, but so fortunately there is a very good collateral from diagonal to the circumflex. So can I show once again? It doesn't move. So that it's okay. It's okay. So, after crossing the Sion wire with caravel molecule catheter, the wire could advance to distal circumflex. But unfortunately, the caravel couldn't cross pass the distal part of the channel, so that change molecule catheter to fine cross, and then fine cross reached here. Sorry, it doesn't move. And so after that, change the guide wire from Sion to ultimate blocks to attack from retrograde. And retrograde wire and antigrade wire is so nearby. So that after that, checking IVAS and then perform the reverse cut. It's a normal way. And then after crossing the retrograde wire, change the wire to RG3. So the point of this case is that there are so many bifurcations as a distal part of the CTO. So in some situation, of course, we can cross the wire antigradally. It's okay, but sometimes it shortcut or it makes a hematoma if we do parallel wire something. At that time, we sometimes lose branches, as first case of RCA I already showed, like that. So after the stenting, I'm sorry. The final result, I couldn't. It doesn't move. I'm so sorry. But so all the branches are very nicely preserved. So this is the last case. This is not a really CTO, but this is a ACS case. 63 years old female, ambulanced on Sunday. So holiday, and due to severe chest pain from 2 days ago. And so already cardiac enzyme increased and the ST elevation was shown still like this. And so left coronary system is okay. And we can see the slightly collateral from left to right. We can see the collateral to the right, distal right coronary, and so proximal RCA is occluded. So this is not really CTO, but so this is a recent myocardial infarction, and so this is a holiday, so that young doctor in our hospital do the PCI from radial approach, 6 French guiding, and using the Sion blue. He think it's easy, but unfortunately the wire couldn't pass the region. And so after guiding catheter injection, so dissection occurred like this, and he injected again, so that the very big hematoma formation like this. So it's totally difficult situation. And so use another wires, but of course, very big hematoma, so that it is totally difficult to cross in that timing, in Sunday. So he called me, please help. So that this is IVAS image. Can you see? So it was a very big hematoma. Yeah, so we can see this is a very big hematoma like this. So how to get this small lumen? So of course, in this situation, I use a parallel wire with using dual lumen catheter like this. But still, the IVAS and also the second wire also in the subintimal space. So proximal part, it's okay. So using DLC, I can get. But distal part, the wire also, once again, go to the subintimal. So that change the wire again and again, a little bit intermediate wire. But so finally, I couldn't get the distal part, still subintimal. So that proximal part, I could get in there, so to lumen. So in this situation, so IBUS guide wiring impossible, 6 branch guiding catheter. What we can do? Exchange to big guiding catheter or double guiding. So next guiding catheter for IBUS or start retrograde and ADR, any options. But so in this situation, check the LC angio again. We see the retrograde channel, so collateral channel from septal, so that I do the retrograde approach for ACS like this. So from using microcatheter and so 03 wire, easily pass this septal channel, so that after reaching distal RSA, it is easy to cross the wire from retrogradely using reverse wire technique. So with the IVAS, retrograde wire is in the true lumen. So finally, reverse cut technique and so externalization, and then final IVAS showed all totally true lumen. So that just putting stent and final result was very acceptable like this. So this is so last slide. So retrograde approach is an option, an important option in some situations like this. Not only CTO case, but so this technique sometimes useful for ACS in some complex situations. And use 7 French guiding catheter is very important for retrograde or CTO PCI. And careful reading of CAG and operative strategy is very, very important. Step by step and careful approach also very important to avoid complications. And if you have some problem or difficult situation, consult to experienced doctors, also very, very important to perform appropriate retrograde CTO PCI. Thank you for your attention.
Thank you very much for the excellent presentation. I think you stop for a while and then to ask a quick question for you, because it is a very top section of the retrograde approach. So I would like to ask Dr. Takuma, do you have any question for Dr. For this section or not?
So thank you for the great lecture about the retrograde case, Nishia-sensei. So my question is about the how many I often go also C2PCI in overseas hospital. So and I teach some the young doctor also. Then they want to do the retrograde of PCI.
Yeah.
But I performed the C2PCI. But in your experience, how many case was enough to do the retrograde C2PCI for young doctor to lecture to become a matured?
Yeah, maybe it's a very difficult question. So, so of course, so the enough PCI experience and also not enough CTO PCI experience, both important. But for example, maybe if the so wire integrated wiring, so especially so basic techniques, so parallel wire or so using the intermediate wire or integrated wire escalation. If the doctor enough understanding at that time, we for my experience, I let the local doctors, so in Japan or overseas countries, I let them to do retrograde approach. And if it is not enough at that time, I do by myself first. And so if they see enough at that time, so proctoring or so let them to do CTO. Is it okay the answer?
Okay. Then you mean that the skill of the young doctors, it depends on the skill.
So one more short question for you, because usually we go the retrograde, so the patient at the opposite side, depending the the collateral from the other side.
Yeah.
So when we borrow that vessel in order to go put the microcatheter in, so the patient has the symptom on the table. So in that situation, how do you solve the problem? Because the patient have the chest band.
Yes,
When we
yes,
put
yes.
the microcatheter in, the patient on chest band, and even
Yeah.
sometimes it's the blood pressure going down. So
Yes, of course, it's a very important point. So if the only the chest pain and the ECG is no change, and also hemodynamics, blood pressure no change, at that time we can still continue giving some chest pain reliever or something. But if the hemodynamics no good, and so for example LED flow is no good or ECG change, at that time of course we have to pull back the microcatheter. We can sometimes only put one ear is okay, but sometimes microcatheter at that time it's sometimes difficult.
Yeah, I think it's also echo with the planning is very essential because sometimes you have many retrograde options, but some of the retrograde channels is the only dominant one, particularly the epicardial one. And then when you cross the wire together with microcatheter, then you have lots of accordion, and then the only surviving retrograde channel you jeopardize, then you pop. So I think planning is going back is. I mean, that may be the least choice of using that channel. Maybe you're using other channels. So the channel choice is very lots of art more than science because to one operator's master, they may use a really challenging, but I think there's also some wisdom behind the risk and benefit ratios, the ECV crossability, etc. I think this is also taken into account.
Such kind of situation often occurs in the epicardial channel. For example, direct apical channel. So such kind of channel, if we put the microcatheter, sometimes chest pain and no collateral flow. At that time, so putting the microcatheter and then from inject from the guiding. At that time, we can sometimes see the septal channel. So that if we use the septal channel, we can avoid the ischemia.
yes, Dr. Liu, please.
Or maybe I just ask. There's a lot
The
of
mic
talk.
be behind you.
Oh, it's okay. It's okay. It's okay.
Chair just flipped and did the retrograde. Anyway, there's a lot of talk about investment procedure.
Yeah.
What's your comment on that? And sometimes people talk about the injecting through the microcatheter.
Yeah.
Hydraulic, whatever. Do you do that?
So it means HDR or something. So not retrograde, but HDR. Yeah, in Japan, some doctors do. So, but most of doctors are not agree with that procedure. But only the situation, instantly stenosis, is I think acceptable. Maybe it is less hematoma formation or less dissection, severe dissection. So that instant occlusion is I think it's my opinion. It's a good option for the HDR. So microcatheter injection in the CTO region. It's okay.
Yes, I think it's a bit very hard. So I think I still had a question from the audience, but we have to move to the next presentation, and then maybe we have time to go back to you, Dr.